Oh, he said he was coming. How do you think?
Got him.
Oh yeah, I'm not filming you. I'm filming me. Well, then I'll go ahead and get started. This is Anesthesia for Considerations in Endoscopy, Volume 2. I did another lecture. It's online. It covered more, I don't know, I guess general complications and stuff with endoscopy. But this lecture is going to focus just on a couple of, I don't know, randomish topics that I was told y'all had questions about. And so we'll go over those. So I titled this one The Revenge. Okay, so this is what we're going to go over, okay? Emergency cases and just some considerations to think of when we're doing emergency cases on the weekend and whatnot. Rapid sequence induction. What is that? When do we do that? What does that even mean? And the third thing is cricoid pressure, which is kind of a part of rapid sequence induction. Okay, so we'll start off with talking about emergency cases. So what is an emergency case? Well, first off, this doesn't actually need to be an emergency. It's really just something we say for non-elective cases. This is pretty much any case that just can't wait. Add-ons, whatnot, that are not necessarily add-ons we're getting to the end of the day, but more of a add-on or weekend case that is like they're coming straight up from the ER with usually these sorts of things. Food impactions, any sort of GI bleeding, and it's not necessarily limited to just those things. So why would I be talking about this? What is unique to these add-on procedures that come straight here? The one really unique thing that differentiates them from an anesthesia standpoint.
Full stomach?
Full stomach. So the patient is an NPO or they're at some other risk for aspiration. So perfect. The ASA fasting guidelines are pretty well established at this point. Does anybody know if they've had a little bit of food, like half a granola bar or something? How long the NPO guideline is for that? 6 hours. Perfect. What about clear liquids? 2. What about a little kid who's getting baby formula? 6. Jess is good at this. What about breast milk? Kids eating breast milk? Same thing, 6? It's actually 4. For whatever reason, breast milk cruises on through the body for little kids. So these are the fasting guidelines. Anything bigger than a light meal or whatever is said to be 8 hours. And they even hedge on that. They're like, additional fasting time may be necessary, blah, blah, blah. So who is this for? This is not for pregnant women, first off. Pregnant women write their own rules. They've got a human being parasite growing in their body. It's sitting right on top of their stomach. Everything changes. So throw that right out the window. Clear liquids. What are some clear liquids? Here's some examples of clear liquids. Pretty much anything, what do we say? If you can, put it on top of newspaper and like you can read through it, then it's a clear. So lots of different things. Gatorade's a clear. I believe our prep for colonoscopies is considered a clear, even though you mix like a lot of drugs in with it and everything. The whole point of that is to create motility. So it should be rocketing through your system pretty quick, but I don't exactly have a lot of evidence of that. I may be wrong, but until otherwise, just think of that as a 2-hour deal. Black coffee, meaning nothing in there. Clear tea, also, you can put sugar in it. That's not a big deal.
Honey's the same thing.
Honey's the same thing? Okay. Yeah, honey's just sugar, really. So I don't see why that wouldn't be.
A lot of people want their honey and
Honey and tea. Okay, there you go. So there's those things. What is a light meal? Pretty much the example they use is like some toast and clear liquids. Not many people are really pulling off light meals when they're NPO, or not NPO, I mean. It's usually more stuff.
Not untoasted bread.
Say what?
Specifically says
Specifically toast. That's just the example that the ASA gives in their fasting guidelines. I just wanted to report it like that. But no, it's like some sort of little snack is probably 6 hours. Anything bigger, anything with, like they put on here, fried foods, fatty foods. Fatty foods includes dairy, meat, things that are going to have to sit in your stomach and take a while to digest. That is what's considered to be not a light meal. Okay, any questions about this before we move along?
Eggs.
Eggs will probably be, I would say, heavy meal. Just because it's essentially a lot of lipids. So I would say 8 hours for that. But anyways, the reason I bring this up is you got patients coming from the ER. They're probably not in PO. Does that mean we're not going to do their case? No, we're almost always going to do it. It's just if a patient isn't in PO, then I have different considerations. So I'm going to bring up pediatric patients and all this stuff. What if we have a pediatric patient come that's not in PO? This is the biggest thing right here, is that the patient needs to have an IV. You will have people in the ER say something to the effect of, oh, this baby's coming up because they've got, maybe it's a 4 or 5 year old. They've got a food bolus or food in their esophagus because apparently they have EOE and nobody has diagnosed it until now. And one of the nurse goes, oh, we'll just have anesthesia put it in when they're asleep. Can't do that. You can't do an inhalation induction if someone's at risk for aspiration, because you will start that induction and then you just, whatever time between induction and putting an ET tube in is this risk for aspiration. So I don't know about some of the other guys. It is not recommended to do an inhalation induction on kids with no IV and a full stomach or something in their esophagus, or not many kids have GI bleeding, but same thing with an adult sort of deal. If we're thinking anything's in their stomach, they need an IV. That's the fastest way I can put them to sleep and the fastest way I can secure their airway. Yes, patient is not NPO. I don't know why I added that. In terms of the size of an IV, for me, doesn't matter. I don't care if a full-grown adult my size has a 24 gauge IV. I can put them to sleep with that. I can secure an airway, and then I can get another IV. If we're getting in there and we're doing crazy stuff with bleeding and we need to transfuse or something like that, then we can do that. But anyways, those are the considerations there for pediatrics. Alrighty. If you're doing a case on the weekend or overnight or whatever, I get called in, I come in, and then I kind of figure out the age of the kid and all these things. I try to send the message forth to whoever is already ahead of things. Hey, let ER know the kid needs an IV. Help me with that kind of thing. Are we good on this? Any questions about pediatrics, at least for this aspect? Okay. So next topic, rapid sequence induction. That kind of segued from ER patients with full stomach. What is an RSI, also known as rapid sequence induction, and some fancy people are calling it RSII, which is rapid sequence induction and intubation. It's all the same thing. You're not going to do a rapid sequence induction and not intubate somebody. Those are just the fun versions of ways we call things. So there's the different kind of names and things. So what is this for? It's designed to minimize the chance of pulmonary aspiration in patients who are higher than normal risk. So basically, the quicker I can get them asleep and put an ET tube in their throat, in their airway, that's going to minimize the aspiration risk. Aspiration risk is usually tied to time until tube, right? So I can put you to sleep with a full stomach, but I probably got to do something relatively quick. Is this foolproof? No. There's still a risk for aspiration even with an RSI. But this is the proper way, kind of the board answer, if you will, on how to take a patient with a full stomach and put them off to sleep. So indications for a rapid sequence induction. Anyone that's full stomach or not NPO, definitely. I mentioned pregnancy earlier. Anything that increases the intra-abdominal pressure. So you got a baby on there. If a patient has really big ascites, we see that a lot. Obesity actually factors into this. The bigger you are, the more pressure when you're laying supine you're going to have on your stomach, and that's going to push whatever's in there up. Also, we see this all the time, certain GI pathology. If you have an obstruction somewhere, whether it's a small bowel obstruction, pyloric obstruction from an ulcer, whatever. Gastroparesis, if they have really bad gastroparesis, this can be caused by that, even if they're NPO for 8 hours. These are independent of NPO status, the certain GI pathology and the increased interabdominal pressure. Something else I think I thought to throw in here, make sure to have suction available. Like the anesthesiologist needs suction. Dr. Jaffe needs suction. Because if all of that starts coming up, the only thing I can do at that point is just to remove it and try to get a tube in as fast as I can. So suction is a definite for all these RSIs.
We also talked about sometimes like your suction might be over to where you are. You know how we have the suction, we can also put another canister.
Correct.
And we could have like...
You have lots of suctions.
Yes.
I've never had too much suction in my whole life.
The suction machines that are attached to your machines suck.
They're very
Because
good.
they don't suck.
Well, the Neptunes are like super
The Neptunes
industrial.
are great, so I don't know if there's
Yeah.
a problem with your machines. I know I've had Biomed trying to look at them before.
Well,
That's the best we can do.
on the anesthesia
Full
machine,
suction.
you can switch it to the wall,
Yeah.
basically full suction, and that's actually pretty robust when just coming through a yank hour. But if you flip it the other way, you can use the dial to adjust how much suction, and if that's low,
Okay.
then you're not going to have much suction. So
Maybe we need to work on that.
just ask if it's full suction or not.
Okay.
But even with that, it is less than a Neptune. That Neptune's a doozy. Cool. So what are the steps of RSI? The first thing you're going to do is pre-oxygenate the patient. The biggest consideration when I'm rapidly putting someone to sleep is that I'm not going to bag them. That is, if you're bagging someone, that's not really a rapid sequence induction. That's the big differentiator, is you're just going to oxygenate, push a bunch of drugs, and then they're going to go off to sleep. I'll just pull up all the steps here. Positioning, you're going to have them relatively head up, maybe definitely not head down like Trendelenburg or anything, because you'll put them to sleep and everything will go with gravity. So you're going to have their head somewhat up, and in a sniffing position would be ideal because that's the position you intubate in. You're going to push induction medicines, usually something to go to sleep with, like propofol, and then something to paralyze, like succinylcholine or rocuronium. And then you intubate. No bagging, none of that stuff. Hopefully not a lot of dilly-dallying. I have had patients where I've done that, I've pushed meds, I go to look, and I just see gastric garbage, meaning that they've already aspirated. So then I got to get suction, and I got to suction stuff before I can even see where to intubate. That all takes time, but at that point, it's kind of ship has sailed. But these are kind of the steps to go through in the considerations of what an anesthesiologist is thinking on anyone that should be a full stomach. Cool. Any questions about any of this stuff?
Cricoid pressure.
Cricoid pressure, right there. Let's talk about cricoid
Can I
pressure.
ask you a quick question?
Yes.
So what about semaglutide? Are you guys starting to look differently?
Yeah, so that is a new fun little hot topic in anesthesia. So back here when I said indications of full stomach and things like that, the recommendation for us at least is to probably stop that drug. Do y'all know what he's talking about?
Ozempic.
Wegovy, Ozempic. No, Ozempic?
Ozempic is semaglutide.
Okay, that. So
Diabetes drugs that's
yeah.
like gastric emptying.
right, it's everybody's taking it for weight loss now. That's the new hotness, is to take these. What is it? It's like a glucagon-like peptide thing. I don't know. I feel like you would know. But basically what it does is it slows your gastric emptying.
GLP-1 agonist.
Yeah, glucagon-like peptide.
Yep.
So yeah, those weight loss drugs are real common, or getting more common in the general group of people. We're trying to figure out these patients that are on it and get them to stop a week before they come in. Theoretically, if they haven't stopped it, we're going to treat them like a full stomach. There's some thoughts of maybe learning how to do point-of-care ultrasound of the stomach, to where you can actually put ultrasound on the stomach and see what's going on. I have no idea how to do that, but people are learning how to do that, and apparently that's a thing you can do and go, oh, there doesn't seem to be anything in there. We can just do it. Yeah, bladder scan for the stomach. That's kind of how that goes. So that is a new sort of thing. Right now, the recommendations are just to stop that drug a week in advance. But again,
And so that
hopefully
drug
we've stopped
slows
it.
the emptying
It slows
process?
gastric emptying, so that patients that have followed the MPO guidelines may still have a full stomach, is the worry, right? So yes, that's definitely a thing that we're running into. So now we go to cricoid pressure. What is cricoid pressure? So during a rapid sequence induction, a lot of my colleagues will probably ask you at some point in time, hey, I need cricoid pressure. Well, what is that? Let's go through a little bit of the history, okay? This thing is also called a Selleck maneuver. Your cricoid cartilage is just underneath your thyroid cartilage. So if you feel there's a cartilage on your neck and it's got a little V-shaped deal in the midline, that's your thyroid cartilage. It is the cartilaginous ring just below it. What's unique about this ring? It's the only cartilaginous ring that is a complete ring in your trachea. Everything else is kind of horseshoe shaped. This one is actually a full circle. So the idea from this guy back in the day, from Dr. Selleck, was that maybe you can use this full ring to your advantage, push down, and actually occlude the esophagus, which will prevent regurgitation and aspiration. So in 1961, he came out with this paper and a study. Cricoid pressure to control regurgitation of stomach contents during induction of anesthesia, a preliminary communication. There were 26 patients involved in this study. That's not a lot. It was in one hospital. It's also not a lot. It's the least amount of hospitals you can do this in. And it was not randomized and not standardized, because back then we just did stuff, right? And he was considered an expert, and so we just took it for granted. So here's a picture of Dr. Selleck. You can tell he's a doctor because he has a stethoscope. Yes. And if you'll notice, he's real sexy and doesn't wear a lot of clothes. So a lot of people really bought into what he said because he's so sexy that they were like, man, this is some sexy science. We should probably be doing this. And so, like I said, the main goal of what he figured out was that if you push down on here, it prevents regurgitation. Oh yeah, so this is the kind of the steps. Apply pressure to the cricoid cartilage, and you occlude the esophagus, and everything's perfect after that, right? So what he originally described was 20 to 44 newtons of pressure, which wasn't based on anything. He just thought that was a good amount of pressure, okay?
You need like a torque wrench to get it?
Yeah, I know, right? So we'll get to that, definitely. So there's some problems with what's going on here. So here's a drawing, sort of like, this cricoid pressure. So here's your cricoid cartilage right here. I've got another model here in a minute that will show you that kind of lays out the different rings of the trachea a little bit better. But you see the little pink thing? That's your esophagus. And that's what gets occluded, right? So here's a few problems that I have with this, and that a lot of people have with the cricoid pressure stuff. Since 1961 to now, which is over 60 years, there's never once been a randomized controlled trial that showed that there was a benefit to doing this maneuver. Not once, okay? So let me just get that out of the box. So we can't show that there's benefit, but there's been a lot of studying going on in that 60 years to look at different things, and we have found some issues with it. 81% of the time, there's some degree of airway compression, which doesn't necessarily help you intubate. 56% of the time, there's actual airway obstruction. 29% of the time, you can worsen the laryngeal view. These guys in 1995 just found that it makes the intubation process even more difficult. Apparently, with pressure up top, you can lower the esophageal sphincter tone and increase amounts of regurgitation, especially when you apply and remove. So that's not good. There's actually been recorded airway trauma, like fractures and things like that when this is going on. And at least one incidence of an esophageal tear, which was caused by vomiting when they applied it, and it caused some version of a tear that was fatal in that patient. So probably thinking of Boerhaave's, but I don't know. So there's our pro-con list, right? Our pros are we feel like it's good, and then our cons are everything here. So I think you know where I'm going with this, right? I don't do esophageal, I don't do cricoid pressure when I do this anymore, because there's this litany of evidence that describes this doesn't work and in some cases can actually be harmful. However, I'm not in there all the time. You got some older guys that I've even brought this up to them and they just get mad at me. And so I'm not here to tell other anesthesiologists how to practice. People have their reasons for doing things, and there's weird indications that may not be exactly what I'm lecturing on. And you know, a rapid sequence induction is very, I guess, a tradition. Routine amongst a person. So if they're expecting cricoid pressure and that's how they intubate and stuff, and they ask you to do it, you should probably do it. Don't give them a lecture. Don't hand them my YouTube number or any of that stuff. Don't link to this video. But that's why I don't do it. And I know some other guys have also seen this amount of evidence. And this isn't even new. This wave started around 2000 of people stopping cricoid pressure during rapid sequence induction. So if you're going to do it the right way. Let me show you the right way to do this, okay? Here's a picture and a nice, example of what I was talking about earlier. Let me get my little pointer up here. So this V right here, this is the thyroid cartilage. It's the big cartilage that houses your vocal cords and all that stuff. And if you lean your head back, that's usually the Adam's apple in guys, because we have huge ones for whatever reason. So if you feel that little V right there, you now know you're up here. You go down, you'll feel a little gap right here. This is actually where you cric someone in the ER. This is the cricothyroid membrane, and then the cricoid cartilage is right underneath that. So if you're pressing by the V, you're too high. You go a little lower than that. That's a good, easy way to find the cricoid cartilage. So if a physician, anesthesiologist says, can I get cricoid pressure? Here's what you do. First off, for cricoid pressure, you need to have a dedicated assistant. The person giving cricoid pressure, that's all. Okay, so that's all they're gonna do, okay, is hold cricoid pressure. You can probably hold the ET tube or something like that as well, but that needs to be your goal. You don't need to be setting up endoscopy, scope, whatever. You're helping the intubation. The correct verbiage is 10 newtons of pressure before induction. What the hell 10 newtons of pressure is, we'll get to in a minute, but it's, I don't know, 30 newtons after induction. So before induction, you press a little, and then after the induction, you press harder, okay? That's kind of the rule. And I'll get to what that amount of pressure is here in a second. And then you're gonna hold that until someone forcibly takes you away. You know what I mean? You will have someone look you in the eye and say, okay, I'm done. But the whole point of cricoid pressure is I'm gonna allow this pressure to stay on there and I'm not gonna let go until somebody says something. I think some of the problems in that last slide are from on, off, right? There is, I mentioned it in here, but there is a thought to be like a reflex that can happen when you press on the upper esophageal sphincter and then let go, food can reflux. So just that can cause a problem, whereas possibly doing nothing would not cause that problem. You know what I mean? Mm-hmm. So, yes, the last thing I put on here, don't be afraid to ask, where's the cricoid? I mean, an anesthesiologist will look at you and be like, I need cricoid pressure, and that's it. And we just we just think everybody knows everything that we do. That isn't necessarily true. If you need a refresher, hey, where do I press? we're the ones that should guide you in that. I mean, if you know, that's super. If you don't know, it doesn't hurt to ask. It takes half a second. You know what I mean? Does this sound good for everybody? Yes, Sue.
Is it different in peds?
It-
If we were to be rarely asked to do it in a pediatric case?
I will again say that none of the studies that have been done have been in pediatrics.
Okay.
That may be a complete different setup.
A different,
No, it's not a different deal. You should still press on the cricoid. It's obviously going to be less of a space. But yeah, but again, cricoid pressure is not valid. I mean, it's just not really validated in anybody, but it's definitely not validated in peds. So I don't know. Everything in pediatrics is a little more floppy, so it's not going to have as much rigidity and therefore probably not as useful there either. But definitely that 10 newtons, 30 newtons is probably going to be too much. You're probably going to compress the airway.
And it's just basically a press straight back.
Press straight
bed,
back.
As opposed to like a pinch.
Correct, no pinchies, no pinchies. This looks like pinching.
Yeah.
There's another technique called burp. Backwards, up, right, posterior. So it's this maneuver you can do to help visualize the airway. It looks a lot like cricoid pressure. It's basically cricoid manipulation. The burp technique, if you ever see that written on anything, is moving the cricoid around to help with visualization. Technically, cricoid pressure for rapid sequence induction is different. It is just pushing, and that's it. Another thing that we also have evidence of is a lot of people's esophagi, is that a word? A lot of esophaguses don't just sit behind. They're kind of lateral as well. So when you push backwards, the esophagus doesn't get occluded as much as it just squirts out of the way. Everything's lubed up in there. You know what I mean? So that's another reason why I don't think this works great. But let's talk about newtons. Who the hell knows how much 1 newton of force is? Huh? Not everyone at once. Nobody knows that since physics. So let's take a guess at how much pressure is 30 newtons. If you do a little Google search, I came up with 6.74 pound forces, which is also 3 kilogram forces. You know how much a kilogram force is? The reason it sounds weird and isn't just a weight is because newtons is actually a measure of force, which can be a measure of acceleration. We're not accelerating anything, we're really just giving pressure, so it's a little fuzzy. So it comes out to about 3 kilos. Pound force is just a pound. Kilogram force is just a kilogram when things are stationary. But when things start moving, that force isn't the same. Does that make sense? Mm-hmm. Anyways, so that's why newtons sucks and nobody uses it for a measure of anything, except physicists because they're smarter than me. So if none of us know how much pressure to give, let's get a model and like some sort of training thing. Wouldn't that be nice if you could have some sort of training aspect that would show you how much newtons you're giving of pressure and give you some feedback. Hey, look at that! Somebody makes one. It's a throat on a weird box thing that will actually show you how much pressure to give. Isn't that lovely? So here's kind of the thing. I found this on NASCO Healthcare. Does anybody know how much this costs?
$1,000.
$1,000 going once. Anyone else? Can I get 1,500? 1,500. Okay. Can I get 1,750? Can I get 1,500 going once? Going twice.
750. 2,600.
Oh, perfect. Yeah, I'll be right
2,600? Did somebody say 2,600? Look at that. Maybe. So NASCO Healthcare sells something called CPT, Cricoid Pressure Trainer, and it is $26.59.95. Why the hell they had the balls to write 95 cents on there? Come on, man. You're already getting a lot of money. You really got to do the 95? Yeah.
Just
Come on.
2,666. Who's going to buy that?
660. But yes, that's why we don't have one, is because that's kind of dumb. So, again, when you're starting, let me back up. When you're giving cricoid pressure, a kilogram at the beginning, just a little bit of force. 3 kilogram steering. That's the best way I can describe you how to do it. Just posterior, don't squeeze. This is just a force backwards. No squeezing necessary. And that's it. Okay, we just got pizza. So y'all start tearing it up. Do you guys have any questions about anything on this lecture or otherwise that I didn't go over that you would like to know? We covered a lot. I don't do cricoid pressure. I'm not going to yell at the people that do. I don't suggest any of y'all say, hey, did you know this totally isn't validated in people? If you really want to. Dr. Robertson said, I've already pissed off some people mentioning this lecture. I know at least one of my partners that's kind of pissed off that I'm giving this. But, say what?
I said, I can guess who it is.
You might be able to guess who it is. But when it comes down to it, you can, it doesn't get a lot of, what's the word I'm looking for? Publicity. It is still very traditional. As time has gone by, different entities have withdrawn support for it. The American Heart Association just recently quit doing it for codes. Why? Because I think you were developing problems with increasing esophageal pressure while you're doing chest compressions and it causing a problem. So American Heart Association goes, you know what? Let them reflux. They're already dead. Let's not ruin their esophagus. And in the chance that we bring them back, you have this irreparable damage, you know? I think there's some other societies and stuff that are starting to pull back on it. The Difficult Airway Society is a body in Europe that started in the UK, I believe, and is now kind of oversees Europe's like how to do airway stuff. I don't think they've totally let go of it, but I think they're starting to. The ASA is still saying you should do cricoid pressure, even though they acknowledge that there's been no studies that have shown any benefit and that there are issues with it. And it's kind of one of those providers do this at your own guidance, I guess. There is a really funny lecture by this top deal right up here. John Hines, I don't know, this Irish guy has a lecture on a drug that he's invented called Cricoid. It's hilarious. You should watch this. It's like a 5-minute lecture about why cricoid pressure doesn't work, and it's pretty tongue-in-cheek and funny. He gave it in 2014, and it's circulated the internet pretty good. Cricoid. So anyway, that's all I got. I've become a pen snob now. So I was at Costco and I came across these Sharpie like ballpoint pens, and I was like, Sharpie makes good shit. And so I bought this pack. Wow. I can't go back.
Your life.
Yeah.
I agree.
They're amazing.
I get it.
The best pen. I didn't know what I was missing.